Their academic preparation needs to be ongoing to advance the health of Montanans now and into the future. And this grant was created in the response to the Institute of Medicine's report, The Future of Nursing, Advancing Health, Leading Change. And so the APIN grant focuses on the Institute of Medicine's research-based recommendation to increase the percentage of nurses with a BSN or higher degree to 80% by 2020 in order to improve healthcare outcomes. Now the challenge with Montana is we have a very rural and frontier state, which makes Montana especially great for those who live here. Montana is very large. It's actually the 4th largest state in the nation, and it is sparsely populated. It's actually 44th in population. Just one of the 56 counties in Montana is considered urban, with more than 50 persons per square mile, while 10 counties are classified as rural. The remaining 45 counties are considered frontier. They have less than 6 persons per square mile. And the Montana Office of Primary Care documents health profession shortage areas in all but 4 counties in the entire state. So as you can see just from those numbers, we have an incredible size, low population density, and more than 3/4 of our state is rural or frontier designated areas. So this really develops a challenge of providing accessible quality health care for all citizens. The basic infrastructure of the healthcare delivery system in Montana counties are built around the hospital, the public health department, medical clinics, nursing homes, and emergency medical systems. So with that, it should give you all an idea of what challenges we are facing in our healthcare delivery system in Montana, and really the importance of nursing in Montana is so hard to describe because it's a very complicated field, but it's an amazing field at the same time. And we have a wonderful webinar for all of you who have joined in so you can learn about what rural nursing in Montana is all about. So I'm so happy to be able to present Ray Fredette, Sue Buswell, and Kathy Helmuth, who will all be giving you a glimpse into their lives as they are all nurses in the wonderful state of Montana. So just a few technical details before we get started. All lines have been set to mute, and you may press *6 to unmute your line. And at the end of the presentation, there will be an opportunity to ask questions. So if you have any pending questions, you can save them for the very end, and our presenters will be happy to answer any questions that you have. Or you can type your questions into the chat box, which is located in the webinar software screen. It should show up to the right side of your computer. So feel free to either type them and we'll address them at the very end, or you can save them to ask in person once the webinar presentations have been wrapped up. So with that, I would like to introduce our first speaker, Ray, who is a nurse in Superior, Montana. So Ray, in order to get started, please remember to press *6 to unmute your line, and you are ready to go. Are there, Ray? *6 will unmute your line.
All callers are unmuted.
There you go. Can you hear me now?
Okay, gotcha. Yep, thanks.
Perfect. All right, hello everybody. My name is Ray Fredette, and I want to thank you on behalf of myself and everybody else presenting today for joining us this morning. And I am very excited and feel privileged to be able to tell you about my working life in Superior, Montana, and what many rural nurses in the state of Montana go through on a daily basis. So Superior, just to give you a little background, is the county seat of Mineral County. We are 59 miles to Missoula, and Missoula houses the closest level 2 trauma facility. The population for Superior is 812 people, and the population of Mineral County is 4,167. Outdoor recreation, ATV riding, hiking, hunting, fishing, and water sports are the most popular pastimes in Superior. And we do deal with traumas primarily, and so a lot of accidents regarding those type of recreational activities do come to us. We are located on I-90, which connects Seattle and Boston. So if you can imagine, that also brings us a very diverse clientele with various conditions involving people who might be driving by our hospital. So our hospital is a 25-bed critical access hospital. And to be a critical access hospital, you have to meet a certain criteria, and that is to have 25 or fewer beds in your hospital. You also have to have a niche, so to speak, in your hospital, and our niche, so to speak, is the long-term care facility that we have, which houses people who are otherwise unable to be cared for in their homes or by their loved ones. We have a lot of dementia patients, Alzheimer's, what have you, and then we also in our long-term care facility have people who might be recovering from injuries such as, a broken leg or something, and these patients are too obese to be able to maneuver around the home that they live in. We also have an 11-bed assisted living quarters, which is essentially unmanned by our staff at the hospital unless there is an emergent or other medical situation. Another criteria to have a critical access designation is to have a 24-hour, 7-day-a-week emergency room, which we have at our hospital, and our emergency room has 3 beds. I just lost the screen. There we go. In our hospital, we also have a lab. We have radiology, MRI, which comes by way of a truck every Monday. We have CT, ultrasound, and mammography. Next slide, please. So some things that are different about our hospital, or I guess my life as an RN, is that you literally have to be ready for everything that comes your way, and potentially there could be a lot of it. So, for example, in a larger hospital, you're going to have a cardiology floor, and you're going to have an ortho-neuro, and you're going to have an oncology and an ICU, and you're going to have nurses who are trained in every aspect of all of those different areas of medicine. At our hospital, we don't have the luxury of having different floors and different providers or specialists, so to speak. And so that means that we have to kind of have an idea of what to do when somebody comes through the door, and we have to be able to identify whether it's an emergency or not, And so essentially, and for me, coming right out of school, I only graduated in December of 2012. For me, that means that I had to basically master triage skills, and I had to master prioritization, and I had to master delegation very quickly. So if you can imagine in this kind of a situation, clear communication saves lives. The second I started working at Superior, I all but tattooed S-bar on my forearm. It's everything, and you don't get a lot of chances to give a provider unclear communication in a setting like this. And so, again, clear communication saves lives, especially in a situation like we're in. Training is a huge part of our, I guess, work at a critical access hospital. It is mandatory for critical access nurses to receive ACLS training, PALS training, which is pediatric life support training, and also we have to receive TNCC, which is Trauma Nurse Core course, which is probably the best training I've had, the best comprehensive training I've had, and it just basically teaches you a simple triage system for any trauma that walks through the door. Another thing that can be an issue, and we've been seeing a lot of this lately, is that there's not always an efficient way in or out of Superior, Montana. We have a lot of people who die at our hospital. They show up in a dire situation, and if it's snowing outside or if it's foggy, icy, first of all, we're not going to get a helicopter into Superior on a situation like that. And second of all, we might not be able to get an ambulance to Missoula quick enough to sustain life in any given patient. And so that's a very difficult part of our reality in Superior and many critical access hospitals in the state. And it's something that you have to be mentally prepared for every time you go to work. And another problem, or not a problem, but a difference here is that you know everybody that walks through the door. And if you didn't know them from growing up in the area, which I did, grow up in Mineral County anyway, if you don't know them from that, you're going to know them because they come to the hospital a lot, whether it is to receive labs or other ancillary services, or it's because they need our help in the hospital itself. So many critical access hospitals do have the luxury of having more than one RN. In Superior, that is not the case. So when I go to work every day, I am the only RN in the facility who is solely dedicated to patient care. We do have another RN, but she's our director of nursing, and for any of you directors out there who are listening, you know that it's not always convenient to provide patient care even if you're needed for that on the floor. So when I go there, I'm essentially the #1 in charge in the hospital, and that was the case the second I started working there, or I should say the second I was done orientation at that hospital. And I think I underestimated that when I was coming out of college and when I was coming to Superior. I underestimated the level of responsibility that that gives you, and I really underestimated I guess the pickle, for lack of a better term, that you can be put in when on the floor all by yourself. So every day I come to work and I have to line out my providers. I get a report on the long-term care side, and I know what's going on with every one of those patients per detailed report. And I also get a report on any patients who are on the med-surg side of our hospital and or the ER, should there be an active ER when I come on the shift. So that's a lot. And what I hear a lot from people who don't work in a situation like mine is that they can't believe that I put my license on the line the way I do every time I go to work. And it's not as bad as it's cracked out to be, because the thing is it's not a secret that we are minimally staffed at our hospital. And as far as the whole team aspect, I'm very privileged to work with a group of providers, which are, you know, a pool of 1 MD and about 5 physician's assistants, and they all know what we're going through. They're all putting their license, quote unquote, at risk the same way I am every time they come to work. And so we work together well. We know our strengths, we know our weaknesses, and it comes down to, you know, if there's something that we don't know how to deal with, you know, we pool together and we get the job done. Another difference here is that we have very minimal ancillary staff. We have, you know, we have 2 people in radiology every day. We have 2 people in the lab, sometimes 3 if we're lucky. We have 1 respiratory therapist, and that's about the extent of it. And so what that means is, for example, even the lady who is in charge of our supply department is cross-trained in many you know, medical aspects. For instance, she's a part of the surgery team in our hospital. And so, you know, when we call a code at our hospital, it's the same at our hospital as others in that you don't know who's going to show up in your room, but what I can guarantee you is there's not going to be another RN, and there might not even be a CNA that shows up in my room to do a code. The respiratory therapist might be there, and the supply people might be there, and even somebody from the kitchen staff might show up when we're running a code at our hospital. And what I can assure you is that things get done efficiently. Everybody is very well trained, but unlike larger hospitals, we have to pull resources where we can get them. There isn't always a dedicated hospitalist, and so what this means basically is that if I have somebody who walks through the emergency room, or if I have an emergent situation, or even just a situation that needs to be dealt with sooner than later in the hospital, I may have to call around the clinic or the hospital to find the provider who's supposed to be with me that day to get them in there. And this puts a big strain on them, because if they're seeing clinic patients, you know, they might have to drop a clinic appointment right then to run over, or I might get the question when I call a receptionist over in the clinic, is it an emergency? And that's where triage comes in, where I can say, no, it's not really an emergency. I just have somebody with a sniffle here, or, yeah, I need you to get them out of that room and over here right now. And that also means that I have to take initiative sometimes, and I have to order labs, and I have to order imaging. And coming out of college, that was not very comfortable for me at all, but I'm just glad I'm at the point now where I can look at a patient and I can say, okay, it's fine to plug an IV in, it's get some fluids running. About the only thing that I won't do at this point is administer medications without a direct order. Which brings me to the fact that we don't have a pharmacist in our hospital, and I know that this is the same in many critical access hospitals around the state. We do employ a full-time pharmacy tech, and she is in charge of ordering a lot of medications, and she does have some limited knowledge on medications, but with the fact that we don't have a pharmacist on staff, that means that anytime we check somebody into the hospital, we do have to go back into our pharmacy, and we have to pull medications, and we have to do all the checks, which is just fine because nurses are well ingrained with the 5 checks, but we also have to cross-reference everything to make sure that there are no contraindications, and we also should have a pretty good grasp on what all the medications will do and what they're used for. In addition to knowing whether or not we have a certain medication in-house, so that we don't get a list of orders and say, well, we don't have this specific medication, what can we do to substitute that medication? And that also comes into play in the emergency room when we have to medicate people in there. Another caveat to my job is that there are no on-call RNs, and I know that this could be secular to the hospital in Superior. I'm sure a lot of other critical access hospitals do have an on-call list for RNs, but we do not. And so where this can come into come to a problem is that if I have, let's say, 4 patients on the floor, and in a 10-minute span I have 5 people come into the emergency room, it could be a real issue if I've got IV lights or IV buzzers going off in the rooms, and maybe I've got a demented patient that won't stay in bed, or I've got a patient that you know, doesn't have a good cognitive status, who's getting out of bed, maybe falling. I mean, and what if I get you know, a massive trauma on the highway, and I get a bunch of patients that, you know, are critical coming into the emergency room? I've got to be able to delegate and round up ancillary staff at the drop of a dime, and just hope that somebody who I call at home is available and also willing to come in and help me at that time. So that, again, leads back to the delegation and prioritization. So in summary, the first one there is a quote that I learned in Hawaii, and I love this quote because of its basic simplicity, and essentially it is what it says. And if you can read it for what it says, it basically, if can, if no can, no can, which means either you can or you can't. And you know, every nurse faces this when they come to a critical access hospital or a hospital in Superior, and some people just flat out, they're not cut out for it. And I hate to say it like that, but you know, this isn't their area of expertise, and essentially, you know, as with all of us, you know, we might just be better off somewhere else. And so that can be a real gut check if thinking about working in a rural environment. One of the things that I maintain to be the best part of this job now, and it was the case when I decided to take this job out of college, is that it is offering me incomparable experience. I don't have ancillary staff to go to. I don't have a wound team. There's no stroke team. If we have a stroke patient that comes into the emergency room, I'm doing it all. And I think that coming out of college, we're all trained as generalists, in the BSM program or even the ADN program, and coming out of colleges as a generalist and going into the work field as a generalist was a very, very attractive proposition, and it's one that has done me well. With that, it has enhanced my skills. You know, I can do certain things in my sleep now that I have a hard time with when I got out of college and when I first started nursing, and it just kind of goes with the territory. In that, you know, when you go to work every day in a critical access hospital or just any rural environment, you put your own all hands on deck approach to it, and you get better at everything. And I think out here in our area, you are serving the greater part of the greater good, and that you do have to learn how to do so many things, and that you do help such a wide variety of people with all of their different ailments. And there's the bibliography, and I'm done. Thank you very much for listening to my part on rural nursing.
Thank you so much, Ray. That's amazing and great. Gave us great perspective as to how complex it actually is to be a nurse in rural Montana. So very great job.
All callers are muted and they can unmute themselves. Muted.
Well, now
Unmuted.
I would like to introduce our next speaker, Sue Buswell. She is from the Montana Association of School Nurses. So Sue, you are able to go ahead and get started. If you press *6, it will unmute your line. And Ray, if you want to mute your line now that you are done, that would be great.
Thank you, Kaylin. I have to agree with you that Ray's presentation was a real eye-opener, and I admire you tremendously, Ray, for what you are able to accomplish. I'm going to be talking about the role of a registered professional school nurse in rural schools. And basically, the functions of a school nurse, which is the next slide, yes. The thing about school nursing is that many people really do not understand what the role entails. Many of us remember back to our days when we were in school and remember that there was a nurse who put Band-Aids on and gave you hugs, and that was pretty much the extent of what was done. Today, it's a very, very different part of nursing. It's a major specialty area. And some of the functions that school nurses provide are direct health care. So we do a lot of planning, and we actually provide the treatments, the medications, et cetera, as we're going along through our day. We treat illnesses and injuries. We do coordinate school health services, which means that school nurses are basically the major health personnel in a school. They develop protocols for health services, for instance, how life cases might be handled and that sort of thing. And they're very important to the functioning of the school where it deals with the health of the students. We collaborate and communicate with students, parents, healthcare providers, teachers, and administrators. And this means we're part of a team that works together. We involve our students and our parents directly. They are a very big part of planning the care and carrying out the care. We facilitate access to primary care and community resources. And we promote preventative care and a healthy lifestyle. This involves teaching and also infection control and all those sorts of things in our buildings. Okay, next. One thing that is very important in our practice is that we have to follow along with federal laws to ensure safety and provide access to education. And these federal laws include Section 504 of the Rehabilitation Act, the Individuals with Disabilities Education Act, and the Americans with Disabilities Act. basically what they entail is stating that children with special health care needs have the right to be educated with their peers in the least restrictive environment. And this is one of the major things that school nurses do. They make it possible for students to receive health care on a daily basis that they might require while they're at school, and they provide accessibility for those students to be in the environment. They develop the ways that are the methods that the student is going to use in order to continue to be in class as all of their peers are. Slide. Yep. The reason that school nurses are so important is that they have a tremendous impact on school attendance rates. And those attendance rates affect such things as student learning and performance, standardized test scores, graduation rates, dropout rates, parent employment, and school revenue in states that fund education based on attendance. And Montana does fund education based on attendance. There will be a particular day or two during the school year where all schools will be called by the state to find out how many students are in their building on that particular day. And that's what the education funding is based on. So if there are a lot of students missing from school on that day, the schools don't receive the funding that they need to take care of all of their students on a yearly basis. So school nurses are critical in getting funding for education by working to prevent absences in students. And also parent employment is one of the things that we look at here. Parents who have to come home from work to take care of their child when their child is ill oftentimes have a great deal of difficulty. In some jobs, they simply cannot leave because their employers will not allow them to, or they do not have any kind of sick leave to use. Those sorts of things happen frequently. And so we want to keep the kids in school healthy and learning, and the parents then will have their opportunity to stay employed and work productively for their families. And next, it's important to know that 15 to 18% of children and adolescents attend school while dealing with a chronic health condition. This is something that is just amazing for many people to find out, that up to 20% of children in our schools could be dealing with a chronic health condition and requiring help to be in school. And a lot of this is looking at the increased incidence of chronic health conditions in school-aged children at this present time. There's a tremendous increase in juvenile diabetes. Most of us have perhaps 3 students in an elementary school that have juvenile diabetes. It just is on the rise, and these kids are in school and need assistance to access their education. Asthma is on the rise. Food allergies are a big issue that we deal with, and those can present particular problems with emergency situations that I'll talk about a little later. Epilepsy, neurological disorders. A lot of these issues are related to issues that occur at the time of birth of a particular child. Cerebral palsy, epilepsy, many of these things are related to the care that newborns now receive, excuse me, which gives them a longer lifespan and a greater probability of making it through that critical period and living with these disorders that they now have. And chronic pain conditions such as juvenile arthritis are on the rise. Migraine headaches are another chronic pain condition that we see a lot in children. The school nurse's role in providing care to these chronically ill students involves some of the following functions. First of all, we do a lot of identification of diagnosed and undiagnosed students with chronic conditions. It's our job to search out and find those children in our schools that have a diagnosed condition. It's part of the assessment process, and most of us are able to do this at the beginning of the school year by parents filling out sheets, health history sheets that identify their kids with issues. And so that's a big part of the job, particularly at the beginning of the year. But also, we are identifying undiagnosed students with chronic conditions. The child who comes into the nurse's office coughing, wheezing, short of breath, and the following week comes in with the same symptoms. And those are kids then that we would discuss with the parents the need to contact their primary care provider to check and see if the child might have asthma and if he could be receiving medications that would prevent him from having to leave PE class in the middle of the class. The development of the health care plan, which is a nursing care plan for individual students, is a professional nurse's role. And it needs to be done by a registered nurse. We are wanting very much our school nurses to also have a bachelor's degree in nursing. And the majority of school nurses in Montana do, probably up to 96 or 97% of school nurses in Montana do have a bachelor's degree or higher degree. One of our roles is safe and effective management of chronic health conditions during the day. So that health care plan that we've developed is going to identify what sorts of treatments the child might need, what sorts of medications, how to identify for teachers and other staff in the school what to look for when there might be a problem, what to do when there might be a problem, and that sort of thing in terms of the plan and carrying out the plan. And then intervention, we provide direct care, and that is dependent on how many students a school nurse has to take care of or how much time a school nurse is able to be in the school. So there is delegation going on as well. And as Ray said, you know, sometimes some nurses are comfortable with that, some nurses aren't. It is a difficult issue for many school nurses because they are alone in that setting providing health care, and they may not be able to be there enough time for a period of time that they can provide the professional nursing care that's needed. And that brings in the training of unlicensed staff to provide care. We also provide assistance for students in self-management of chronic health conditions. And that is a big educational role because we see these kids frequently, at least on a daily basis. And we're able to work with them and teach them more about their health condition, assess how they are managing their medications. For instance, I have worked with many elementary school children who have an inhaler for their asthma, but have never been taught how to properly use it. And they come in and I see them just puffing air in their mouth, puffing the inhaler into their mouth, but they're not using proper technique and they're not really getting the medication that they're trying to receive. So that's an opportunity again for us to step in and teach, to work with both the student and the parents in providing the child an opportunity to manage his degree on manage his health condition on his own. Montana school nurses, especially in rural areas, are also a source of primary health care. For increasing numbers of Montana children, contact with a school nurse is the only consistent access to a healthcare professional available, especially for preventative care. It's very common for a parent to send their child to school when the child is ill and call the nurse and say, I didn't know if he was sick enough to stay home. Can you check him and let me know if he can stay at school today? That's a very common incident. It's also common for parents to call the nurse and say, my child's been having these symptoms. This has been going on. I don't know what's happening. Is this something I should take him to the doctor for? So we do a lot of physical assessment, and we do a lot of referral for parents, and we involve them in the care of the child if we find that there is an issue that's going to be need care on an ongoing basis, that sort of thing. So in many instances, the school nurse is the primary care provider. Many of these children aren't seeing a pediatrician or a physician because there isn't one in their community. The registered professional nurse is the only school staff member who has the skills, knowledge base, and statutory authority, otherwise legal authority, to fully meet the health care needs of children in schools. And that brings up another issue, which is emergencies at school. Emergencies may occur as a result of acute or chronic health conditions. And the school nurse is the professional responsible to plan for the response to a health-related emergency. In a city such as Helena, where emergency services are readily available within 5 minutes, you can have someone at a school to help with an emergency. This is the dream of what most school nurses would like to have, but particularly in our rural schools, that is not always a possibility. And as Ray was pointing out, in the emergency room at school, in the emergency room at his hospital, there aren't a lot of people to handle emergencies, and with the school nurses in that area, there aren't a lot of people to come to their aid for emergencies as well. So you have to be pretty good at doing basic life support and preparing for emergencies, and as much as possible doing preventative measures to prevent emergencies from occurring in the first place. Next. I'm going to mention SB 165, Senate Bill 165, which was this was a bill that was written by Montana school nurses, by the Montana Association of School Nurses, and supported by the Montana Nurses Association. And this bill went through our legislature in 2013, and the response to the bill was unanimously approval. And we're very proud of this bill. The reason that this bill came up was that rural nurses in particular were not able to handle a lot of emergencies in their school related to anaphylaxis. And SB 165 was an act allowing schools in Montana to maintain a stock supply of epinephrine, an EpiPen in other words, to be used in the event of an actual or perceived emergency. There were schools doing this prior to SB 165. There were schools who would not do this because they felt it was illegal to stock emergency medications without an order for a specific student. So there was a lot of question as to whether this was something schools could do or not. So we decided we would create a bill and make it legal, and then it wouldn't be an issue anymore. And it's voluntary. Schools may stock an EpiPen or an AVIQ to be used in the event of an emergency. Section 1 of this bill reinforces a previous bill that previous law was related to the self-administration or possession of asthma, severe allergy, or anaphylaxis medication. And Section 1 provided students with the opportunity to carry their asthma, anaphylaxis medications on their person and self-administer them in a situation that required that medication. And then we added Section 2, which is the emergency use of epinephrine in the school setting, which, as I said, allows schools to maintain a stock supply of epinephrine. Slide, yeah. The ratio of school nurses to students in Montana is abysmal. The recommended ratio is 1 nurse to 750 students. And in Montana, the actual ratio is 1 nurse to almost 2,000 students. Montana ranks number 42 of the 50 states in nurse-to-student ratio. 26 of our 56 Montana counties have no school nurse, and those counties tend to be the counties that CAHN described as rural or frontier counties. There is no school nurse. 98% of all Montana students have no RN school nurse or too few school nurses in their county. And this map is going to show you what the outlook is here. The counties that are highlighted in the very, very dark green have no school nurse. So you can see most of these are rural frontier counties. In the areas of the lowest population, do not include in general the counties that house a major city such as Bozeman, Helena, Kalispell, or Missoula, that sort of thing. What's particularly interesting here is that, and Kathy Helmuth is going to be talking about public health nursing in Richland County. You can see there are no school nurses there either. The areas around the Bakken oil fields have no school nurses for the most part, and the difficulty is that many of these families are transients coming in and out of the oil field areas. They may be homeless, they may be living out of cars, they may come into a school, be there for a couple of months, and move on to someplace else. And so there's a real scramble to try to get those kids involved in the healthcare system. They are falling through the cracks everywhere. And for instance, they may come in, you're waiting for their immunizations. The immunizations come and the immunizations are not up to date, and they move 2 days later and go somewhere else. So it's a real challenge in those areas, in particular in Montana. And next. So factors that affect rural school nurses and their students particularly are, number 1, communication with families. It's often difficult to get in touch with families in rural areas. They, particularly during the school day when their child may be sick or may have an accident or an injury and the family needs to be contacted, because a lot of these families are working not just in jobs where they're paid by an employer, but working in jobs on their own ranch or farm or that sort of thing. And may even be out of cell phone range and not available to communicate with. Accessibility to medical resources and healthcare specialists is very difficult in rural areas, and Ray really pointed that out so well, that even though there may be a medical resource, there may not be access to that resource at the time that it's needed. The distance between the home and the school can be tremendous. Students can be on buses for an hour in the morning, an hour in the afternoon, an hour and 15 minutes getting from home to school. Once they're there, if there's an issue, that does mean that somebody has to come and drive an hour to get to the school and pick up the child and take them home. Or, for instance, a problem could be that we might have an immunization clinic at one of our schools, and we might schedule that for the hours immediately after school so that, for instance, parents who are coming in to pick up their children can take advantage of the immunization clinic and get a flu shot when they come in to pick up their child, that sort of thing. But some of these distances are just too great for the families to be able to participate in the immunization clinics that are being held. Weather is a huge factor. We know that weather's a factor all over Montana, but especially when you're driving huge distances and the weather is scary, to say the least. It's tough to get people in. It's tough to get kids into school. It's tough to deal with, for instance, kids who have asthma, whose triggers are cold air, and that sort of thing. So weather has a real impact on students in rural schools. The accessibility to emergency care, as I mentioned previously, is oftentimes 45 minutes before an EMT or a paramedic or a fireman might be able to come in and assist with the emergency that's happening in the schools. And that is where the rural school nurses have to plan very specific methods to take care of kids if they are having an emergency. So, for instance, a child who is at risk for anaphylaxis, the school nurse is working with the parents to have emergency medications there that are specifically there for that student. Parents will provide an EpiPen or an AuviQ or 2 EpiPens to the school to be used if their child has a problem. And in addition, those school nurses can now access EpiPens to keep in their school, not only for these kids who we know are going to need them, but for those 5 to 8% of kids who have an anaphylactic reaction at school and were previously undiagnosed. So we do as much as we can to provide opportunities to keep those kids going until they can be taken to an emergency room. And it might be the nurse that ends up putting the child in her car and driving to the nearest emergency facility rather than wait for the emergency crew to get out to the school. Isolation is a problem. As Ray mentioned, in Montana, so many of our rural areas have very few people per mile. And that provides some difficulty in school nurses communicating with the families and with the children. It also provides problems to the school nurse because the school nurse is working pretty much in isolation as the only healthcare provider in that basic area who has access to all of the kids in the whole town, but is alone and making decisions on a moment-to-moment basis as to what these kids are going to need. And, you know, there's really not always a person to bounce that off of. So as Ray has to be a specialist of every kind, including a pharmacist and everything else. So do school nurses. They have to have a specialty in every area of pediatrics in order to provide care to the kids. The schools are also often the community center. So that's something also the rural school nurses are trying to provide health education programs, like I said, immunization clinics, all kinds of services such as that in the schools, because that's where the community congregates frequently. Families are transient, as I mentioned. I've had so many issues that were very, very frustrating and very, very sad, where families do come in, they register in your school, they're there for a couple of months, hopefully, and they tend to disappear in the dead of night, and you never see them again. And we don't know where to send the records. We don't know where to follow up. It's an issue of poverty. It's an issue of homelessness. It's a major situation that we face in Montana. And like I said, lack of health insurance is also an issue, and transportation. So when I would recommend to a parent that they come and pick up their child and take them to the health care provider, many times those parents would say, the car's not here today. My husband had to take the car to work, and I don't have any transportation. Or I would help them to make an appointment at the City County Health Department. And they would call on the day of the appointment and say, I don't have a way to get my child to the appointment. And some of these issues are really, really sad, where, for instance, a friend had offered to drive the child to the health department for the appointment, but now the friend is inebriated and can't drive. And so the parent is stuck again without access to getting their child to the appointment on time. And doctors will frequently say, it's so hard to deal with Medicaid patients because they don't come to their appointments. A lot of this is due to the fact that these parents don't have transportation, and when they do try to get transportation, it just doesn't always work out for the child to get to the appointment at a specific time. So next slide, please. So the rural school nurse in Montana has a very unique job description. We, as an organization, as a profession, feel that school nurses should be registered professional nurses with baccalaureate degrees and hopefully some experience in public health, because so much of school nursing is public health nursing. And it's very helpful for our nurses to have had previous experience in that area. However, it doesn't mean that that a school nurse who has been working in an acute care facility, those nurses also have a lot to contribute to care of children with assessment and care of injuries and emergencies and all that sort of thing too. School nurses have to be a leader. They have to be able to take on the responsibility themselves and lead. They have to be decision makers and problem solvers, and they have to feel comfortable in their own skin doing these things, even when there might be a little voice saying, you know, is this legal? I don't know if this is really legal. I don't know if I can do this or not. But I'm here in an emergency situation, and this is what I'm going to do. And part of that was one of the issues that we faced before we passed SB 165. I need to administer an EpiPen to this child, but there is no EpiPen. The school nurse has to be able to function autonomously, has to be able to work in isolation and make decisions quickly. And a really good example of this, when we were first dealing with H1N1 influenza, The first cases of that were diagnosed in a school in New York City by the school nurse, who one day had, over a period of 3 hours, 20 people come into her office with flu symptoms and fevers, and she triaged at that point with these 20 people, trying to keep them isolated from one another and also providing care to them while she waited for parents and others to come and pick up these children and take them to where they could get care. And these were the first cases of H1N1 influenza in our country. One must be a creative, and that's pretty creative, what I was just talking about. Actually, Maria Pappas, who was that nurse, had the custodians taking temps on kids and helping to keep them isolated and provide care and bring them water and do various things while they were waiting. You have to be a communicator, like Ray said. That is a big, big, big issue. You have to be able to communicate to healthcare providers, to parents, and to children. You have to be able to communicate to teachers and the administration and help them to understand the significance of what these children need and what you are providing to them and why you have to provide these things to them. And so you have to really have a lot of research-based information available to you to allow people to understand what you are doing. And you have to be a really good team member because you can't do it all. School nurses have to be able to utilize available resources such as their peers, colleagues, institutions of higher learning, and state agencies to continue with their education and to further their education. And in a state such as Montana, it can be a little more difficult because there aren't as many opportunities available. But today, you're taking advantage of one of those unique opportunities by attending this webinar. And there are many, many such resources available so that the school nurses and all nurses in Montana can stay up to date and be practicing evidence-based nursing. And last slide. I love this picture because this is a school nurse who worked in West Yellowstone. Now, I'm not going to say that this was the school nurse getting to her school because obviously that's not the case. But we sometimes feel as school nurses that we're fighting an uphill battle. We're fighting an uphill battle to convince the powers that be that school nurses make a huge difference and that they are needed at a 1 to 750 ratio throughout the whole state. And we're very much interested in advocacy. We advocate like crazy for school nurses, and we are forging ahead to meet the needs of every child in Montana schools. Thank you.
Thank you so much, Sue, for your presentation. That's amazing. So many complexities and great benefits of school nurses. We really appreciate you sharing your thoughts about that. So now I'm going to introduce Kathy, who is from Richland County, excuse me. And Kathy, in order to present, it's *6, and you are unmuted, and you will be ready to go.
Okay. Kaylin, are we doing okay with the 1 o'clock time that we can just roll, or do we need to maybe reschedule mine?
Nope, we have everybody still attending, so go for it.
All right, let's roll. Do you want to go to the next slide? I guess a little bit about me. I've done 20 years plus of public health nursing. I've done a variety of other spots in nursing that I never quite fit. All of my 20 years has been in Montana, either in Roosevelt County or in Richland. It's interesting, Kaylin, that you mentioned Ritchie. My family's ranch is halfway between Ritchie and Lambert. So out on 200 in the middle of nowhere in western Richland County. So Kaylin has the map here, shows you where Richland County is. We are a frontier county, and there are some interesting challenges that come with that. I frequently talk about looking at things from both the eagle viewpoint. Think a Native American philosophy here. The eagle flies very high and sees very well. And the mouse viewpoint, who gets down in the weeds and sees the minutia of the daily life. So when you look at this map from an eagle's eye viewpoint, one of the things you should figure out pretty quickly is we're a long way from Helena. And I have experienced that repeatedly over the years, whether it was dealing with the state health department or dealing with the legislature, especially the last couple legislative sessions, because our county's been blessed with some oil revenue. And funny, but people on the other side of the state that didn't know who we were or where we were now know exactly where the Bakken and Richland County are. And so it's been an interesting challenge for us. From a mouse point of view, that geography issue affects how we do our programs. I've done home visits in both Richland and Roosevelt County that were 50 or 60 miles or more, and I was still in our county. And I know there are places on the western side of the state that can do that too, but it is an issue for us. In Richland County, there are some things we don't have that would be useful. We have no college or university campus in Richland County. We have no true community health center. The Montana Migrant Clinic has a satellite clinic in Fairview, but actually that has been unstaffed since last April. There is a rural health clinic that's part of our hospital that's in Fairview, that's the Mondac Clinic. But it's not a true community health clinic like Deering Clinic at Billings or some of those are. As Sue mentioned, we have no school nurses. So we have a lot of those things to deal with. I liked one of Ray's comments. Honestly, I do know a lot of the people that come into our clinic. Chances are, since I grew up in this county, I probably know, if they're a kiddo, I probably know them, their parents, and I may even know their grandparents. And sometimes knowing that history helps you understand the family. Besides our frontier issues, you can see we're right on the border with North Dakota. We have always had border issues. North Dakota's health department is set up vastly different from Montana's. We solve some of those border issues in creative ways. For example, North Dakota has been gracious enough. There are several of us in our health department who have access to North Dakota's immunization registry. What a help that has been, to be able to just log on anytime, day or night, and look for records, immunization records done in North Dakota. Huge. But sometimes things don't work so well. In the old days, 7-8 years ago, we actually did trainings with the Upper Missouri District Health Unit in North Dakota, which covers Williams County, which is Williston, Divide County, which is north of that, and McKenzie County, which is Watford City. I will honestly tell you, we have had very limited contact with Upper Missouri District Health Unit. They're swamped. The Bakken has overwhelmed them. They are just trying to survive day to day, and the time for some of that cross-border collaboration is just not there. Which leads me to our third issue in our county, which of course is the Bakken, the lovely oil thing. We certainly do not have it impacts to the extent that our North Dakota partners have, but we have seen a population change. We've seen increases, fluctuations. I can tell you without even thinking about it that I don't like having to get immunization records out of Idaho, California, or Colorado, but I'll go Texas, Arizona, or Alaska any day. And that's just a partial list of the states that my staff and I have figured out how to get records out of. Occupationally, it's impacted us. We had an oil field related accident, and we ended up with 25 people we had to do hepatitis B vaccinations on. Actually, we twisted their arm and got most of them to do Twinrix. If you're going to poke them, we might as well get Hep A coverage too. One of the interesting issues, tagging on Sue's no school nurses, I'm not sure where we're setting this year, I don't know that the numbers have come out in 2014, but I believe it was 2013 that the Sydney School District, for the Office of Public Instruction, the Sydney School District had the highest, or one of the highest in the state numbers, according to the McKinney-Vento Act, which looks at homelessness. You are still considered homeless under that act if you have school-age children and you live in a temporary housing such as an RV. So those are some of the BACN issues we deal with. Kaylin, if you'll move to the next slide. A little bit more about me. I had a lot of childhood experiences with healthcare as a patient, and that was really what led me into nursing. That, and I had a mother who, prior to me being born, had worked in surgery as a scrub tech, and back in Central Supply, she remembered sharpening needles. So those two things made me want to be a nurse, and I was just certain I was going to be a nurse in a white uniform with a hat, and I was going to work in a hospital. I had some great mentors, the first being a high school counselor who in one conversation convinced me to go to a 4-year college. I chose the University of Mary at Bismarck and get my bachelor of science degree in nursing, and I've never, ever regretted that, and I've thanked him many times. The other main mentor I had was Mary Alice Rabine, and she is an icon in public health for sure in eastern Montana. And Mary Alice started mentoring me as a freshman in college, and boy, she just kept on. She gave me my first job in public health and was one of the best opportunities. As part of that job, I got to go to a training, happened to have a public health nurse from Roosevelt County there. I got laid off because of a budget cut. She needed a nurse in Roosevelt County. Ta-da, there I got a job. And I will tell you that in public health, that network, that ability to know who's where, who can help you with what, who might have a position open, who might need somebody, is very useful. You can move to the next slide, please. There is no such thing as a typical day in my life. I will tell you what I've done thus far today. At 8:30 this morning, I had child protection team meeting. There were several issues brought up there with families I'm not familiar with. I came back, jumped on MTRAX. I talked to the nurse at the pediatrician's office here in town. We compared notes, tracked down some of the kids. We've got some toddlers falling through the cracks. We will find them. I prepared for this conference, and I'm on it now. I have an immunization clinic from 1 until 4 today. Yeah, I've dealt with asthma program today. Yeah, so that was pretty much today. Little bit of everything. My current job description is 3 pages long. For those of you that don't know, the 3 core functions of public health are assessment, assurance, and policy development. My title is Health Assurance Nurse Director, so I supervise all of those assurance type programs. WIC, family planning, home visiting. We just got an asthma program we're going to be starting. I sit on foster care review team, adult protection team, child protection team. I go to all the senior centers once a month. I am the FICMR, Fetal Infant Child Mortality Review Coordinator for our county. Yeah, I'm sure there's other things I'm skipping, and that's fine. I put skill sets in there because I have to tell you, I have a bachelor's degree in nursing and a minor in computer information systems that I tell people was outdated the day I graduated. But if somebody asked me what was the biggest change in my public health career over the 20-plus years I've done it, I would say computers. And I'm very glad that I don't have to rely on a cabinet full of handouts or a bookshelf full of books that are probably outdated. I actually have 2 monitors, and I don't know how I'd live without both of them. I do an awful lot of Google searches and an awful lot of work on that. So that's an important skill set for public health, especially in rural frontier areas. One of the skill sets, you have to be able to get out of your comfort zone. I'm kind of mouthy. There's a reason I don't work in hospitals. I ask too many questions, including things like why? Why do we do it that way? Why can't we? So that makes me fit public health pretty well. People don't come to me in my office a whole lot. I do a lot of public health work in other people's offices. I go meet with the county superintendents in each of the schools that are in my county. I sit in their offices. My big challenge last fall to them was, great, Montana High School Activities Association is really focusing on concussions, and we're not going to let athletes play when they had a concussion. It's great. So, boys, well, there's one gal, but what are you going to do in the classroom? And they kind of look at me. Now, this is that mouse view, eagle view. Great that MHSA is looking at sports and concussions. How about academics and concussions? How do we expect that kid fighting a concussion to sit under bright fluorescent lights and look at an Excel spreadsheet in a business class? Really? We think he should be able to do that, but we're not going to let him go play football because of his concussion symptoms? Let's talk about this, guys, and how can we make this work so that this kid doesn't fall behind academically, doesn't drop grade-wise, doesn't get frustrated with school. Let's care as much of him in the classroom as we do on the playing field. Now, I got 20 years into this position and 10 years in this county, plus I grew up with some of these people. So I have the ability to walk into their office and kind of be that mouthy. You need to establish credibility. You better make sure you've got your information correct. You better have resources to take with you to give to them, and I did. The other skill set that I've really had to develop, and thank God I grew up on a ranch as part of a ranch business because I learned more of this business skill set, ranching, than I did in my nursing school, and that's the ability to run a business. We are a business. I have to hire employees. I have to review employees. I have to discipline employees sometimes, unfortunately. I have to establish budgets. I have to write work plans, all those kinds of things, which we learned how to do individual care plans in school, and I tell people that public health, you can switch to the next slide, that public health is like having the whole county as a client. So instead of doing INO and TPR on individual clients, I do it on a population. That might be a town, it might be my county, those kinds of things, but the whole client is my county. For me, public health nursing in Richland County, Montana, fits my life. It fits my schedule. I'm not at work at 8 a.m. If I'm at work at 8 a.m., it means something big is going on. I live 43 miles out. I've got chores. I've got kids to get on the bus. I'm not here at 8 a.m. But I have the ability in my health department for me to set my hours. So I work 10 to 6 most days. Sometimes 10 to 7, sometimes later. I have some meetings that go at 7 o'clock at night, so I'm here till 9 o'clock at night sometimes. And I'm okay with that as long as I have the ability to change my schedule and the flexibility. You know, my son plays in a basketball game today at 3. Well, his team does. I don't know that John will play. This year, it's okay. I'll shrug it off. I'll stay here. I've got an immunization clinic from 1 to 4. If he was a starter on that basketball team, I'd have talked to my administrator, and I'd be at the game. We'd change things. We'd change the clinic day. We'd do something. We'd make it work. If you can't tell by my voice, public health is me, and I fit public health, and I'm passionate about public health. And by having a public health job, if I see an issue like that concussion thing, I can be mouthy. I can pursue it. I can go to the media. I can put it on our Facebook page, whatever. It gives me the opportunities to really make nursing my career and do nursing my way. There are certainly challenges and benefits professionally. One of those challenges that your client is the whole county. You have no MD, PA, nurse practitioner. There is nobody here. As a BSN, RN, I'm the highest on the food chain at our health department. I have others with me, thank goodness. There's 3 of us. 3 of our 5 nurses are BSN grads. But, you know, we don't diagnose. We don't treat. We refer a lot to other places. One of the big things I had to learn a couple of times in 20 years, in public health nursing, there is no next shift. There is nobody who comes in, sees that you're exhausted and you've had a really busy day that says, hey, leave that, I'll finish that, you get your charting done and get out of here. That doesn't happen. So whatever I leave on my desk at the end of the night, it's still there in the morning, usually with more added to it, truthfully. So I have had to learn that I do what I can, and the rest waits for the next day. One of the tips I picked up, and I still do this occasionally, is sometimes at night when I go to lock the door and walk out of my office, I will look at my desk and quite firmly, wagging a finger, say, stay. And then I slam the door real quick so it can't follow me home. So that's public health nursing in Richland County, Montana for me. That's it, Kaylin, for me. If we have some questions, I would love to hear what people have to say.
All right, perfect. Thank you so much, Kathy. So I'm opening up the lines for any questions that you guys have. I have a few that came through the chat box already. Feel free to type any into the chat box, or you're more than welcome to ask them via telephone.
All callers are muted. All callers are unmuted.
Okay, so I've unmuted everybody's lines, and so I have a few questions that are directed specifically to our speakers. So first I'll start with Ray. One person asked, how long was your orientation when you started off working at Mineral? I'm not sure if we're muted or not.
Can you hear me now?
Yep, we're good, yeah.
All right. Thanks for the question. That was kind of funny, and I wonder if it works the same at most hospitals, but I was promised 6 weeks of orientation, and that was contingent on my readiness to be off of orientation with another 2 weeks, perhaps, should I need it. And so I went to work on March 7th of last year, and my first full day of work as a charge nurse at the hospital was on April 16th. So I had probably a full 5 weeks of orientation.
Wow. All right. And we had another question for you. Do your shifts rotate, or do you stay on a constant day or night shift as the RN there?
So that's a great question, and that was one of the benefits I saw to working at a small hospital, was the availability of having a set schedule. So I think I've got the best schedule I've ever heard of, and I do work a set schedule, and I work 3 days on, 3 days off, 3 days on, 5 days off. So I work Sunday, Monday, Tuesday, I'm off for 3 days, then I work Monday, Tuesday, Wednesday. No, wait a minute, that's not right. I work Monday, Tuesday, Wednesday, I'm off for 3 days, work Sunday, Monday, Tuesday, and then I'm off for 5 days, and I'm back again Monday, Tuesday, Wednesday. So yeah, I do work a set schedule, and it's great.
Awesome. It sounds like a great schedule. All right. A question for Sue. What do you continue nursing through the summer when the students are out of school, or what do your summers look like? And you might still be muted. I'm not sure if you are. I think we might still be muted, Sue. So press *6 to unmute yourself. I'm not sure if your line is muted still, but I can jump questions.
Sorry.
Oh, do we get it? All right.
Am I there?
Yeah, perfect.
Okay. That's a really good question. The majority of school nurses don't work in the summer. They work the school schedule. It's an excellent kind of a position for parents to be in because they have the time off when their children have time off. It's a teacher's schedule. And in general, I don't think I know of anyone that is working in a summer school program, although that could be a possibility.
All right. And did you receive any specific training for school nursing when you went through your BSN program?
No. I was, of course, I went through my BSN program, I have to tell you, over 40 years ago. So that doesn't say much, but I know that students today are getting information about school nursing, and they're having opportunities to do school nursing in the clinical area. The school nurses tend to mentor students either on a daily basis, or some students decide to spend perhaps a senior practicum or something for several months with a school nurse. So there are many, many more opportunities for nurses to learn about the practice of school nursing.
Perfect. Kathy, I have a question for you that came in. How often are you traveling for your job, or do you mainly stay in one spot?
Oh, I travel quite a bit, actually. I was in Helena in December. I'm going back there here in a couple weeks. I'll be there again in April. I'll be there again in May. Part of that's because of some new funding, and anytime they bring out new funding, they think you need to go to Helena for the training for it, which is fine. It's just, I'm old enough, I've been in this enough, I miss Big Sky, I have to be honest with you. With the old Big Sky Airlines, we could hop on either in Sydney or Wolf Point, be on the ground in Helena by 10, do a meeting all day, head back to the airport and be on the ground at home by 9 o'clock that night. And yeah. So I end up traveling quite a bit. Plus, I'm on the board for the Montana Public Health Association. And so we do have one winter retreat that I travel to, and then our conference in the fall. And yeah, that is a piece of it. Now, not every public health position is going to have that kind of traveling requirement, but a lot of the programs do have some kind of requirement for at least an annual meeting or training of some sort. And most often, those are in Helena. There is the Summer Public Health Institute is coming up this summer, too. So I'll be in Billings in July.
Well, and good thing we have such a big state.
Yeah.
That's a lot of traveling. That's great. So another question related to that is, are most public health nurses working on policy development?
I'm going to say not nurses necessarily. I will tell you, and I'm speaking mainly for myself, but for a lot of nurses I've worked with, I'm not sure policy development is a great strength of nurses. In all honesty, I mean, we do, but at the public level, it's tough. There's a lot of people working on policy development, but in all honesty, I'd rather leave the policy development to the health educators that we have on staff, or to my administrator who has a MBA or those kinds of things. And that's not, I mean, there are a lot of nurses that do policies. I get that. But when you're looking at, for example, we have a health educator who right now is working on a policy with the county regarding sidewalks, because we have places in Sydney where there are no sidewalks, or you can be walking down a sidewalk and halfway down the block the sidewalk ends. So we'd like to get a policy through the town council that talks about that. I will gladly let her and her group run with that versus me stepping into the middle of that. So and it depends on the size of the health department too. We have 17 people in our health department, so I fortunately can let those be with people that have better strengths than me to do them.
Great. All right. And one last question looks like we have that came in, and that's for Ray. You said that you were from a small town or a rural area before you decided to work where you're working, but did you have a preceptorship or anything like that that made you convinced that you would be working in a rural area?
Well, that's a good question. So I'm from Alberton, which is 30 miles from Superior, and it is right on the eastern edge of Mineral County. And my final semester in college, I decided that I wanted to move my family back to Alberton, where I went to school, and pursue a job at Mineral Community Hospital. And I did that blindly. I had no idea what it was going to entail. And so I talked to my teacher at school at the time, and told her that we were moving back to Alberton and asked if I could get my senior leadership and management rotation at Mineral Community Hospital with the director of nursing out there, and she granted that request. So I did spend about 4 months out there prior to going out there full time, and I was offered a job before I graduated, and that was a wonderful feeling.
Perfect. And lastly, we actually had one more that came through. If each of you could touch on how living in a rural area with your families, why, if that is something that is challenging, or what benefits you see by living in a rural area.
Is that a question for all of us, or just
Yeah, whoever wants to answer it. It wasn't directed to anyone specifically.
This is Sue, and I don't specifically live in one of our more rural areas, but I think that from what I've heard from other school nurses, it can be a real benefit because you know the people that are involved. And for instance, as school nurses, you might already know the children because they're friends of your children. You have opportunities to interact with parents on a different basis than you would in an urban area. And there are challenges, but it's also possible to make a lot of change in rural areas. You can be a leader in making changes.
Great. Any other comments from the other two?
This is Kathy. You know, I always wanted to come back. My family has a ranch, and you don't just pick up acres of land and move it. I mean, you come back to where the land is. But I will tell you that one of the things I appreciate the most is that my kids are involved in activities, whether it's school activities, sports, or music, or 4-H. They're involved with the activities with the kids of people I was with. So I know their parents, they know mine. Things like prom dates. Oh, yeah, you're taking so-and-so to prom. Oh, yeah, I played basketball against her mom. You bet. Have her come stay at our house. We'll do this. You know, that community feel, that's why I love it. And yeah, there's challenges. Yeah, there's distances, but it's okay. I'll take those over the benefits.
I think another benefit to kind of curtail off those two ladies there is that we do have healthcare dead zones in this country, and I, for one, think that although that's inevitable, I think it's also unacceptable. And again, to go off of something that I said in my slide, that in being in the rural environment in the healthcare industry, it is serving kind of the greater part of the greater good, and that you know, we can't have people you know, living on a limited healthcare basis. We have to be there, and we have to do it. And I think that that if you have a calling, that you know, you have to explore that to see if it's for you, because again, we owe it to each other as human beings.
And Ray's right. It's not for everybody. You know, I was going to mention that in my public health talk. I haven't heard this for a while, but there was a point in the past when I had somebody who said, oh, you work public health, you're not a real nurse. And it's like, well, yeah, I am. But even public health is not for everybody. I have friends who are great nurses over at the hospital. God bless them. I don't want to come do their job, but they will tell you there is no way they'd come do mine either. So isn't it wonderful that we have a profession that allows each of us to find the area we work best? I couldn't do Ray's job. I couldn't do Sue's job, so I'm glad they're there. But isn't it wonderful there's a spot for each of us?
Well, I think that is the perfect point to conclude things on, that nursing is so diverse just in what we're capable of doing and what type of job fits each person. So thank you all so much for presenting today, and we'll have everything recorded. I'll send it out to all of our listeners. Thank you all for listening in, and with that, I will go ahead and conclude our presentation. If any of you have any questions, feel free to send me an email or visit our Montana Center to Advance Health Through Nursing website. We're also on Facebook and Twitter, so social media at its finest. But other than that, I hope you all have a great rest of your day.